Hi, this is Professor Ndubeze Okonkwo. Um, I'm a biochemist with graduate training in forensic chemistry. I'm a specialist in internal medicine, a subspecialist in nephrology and hypertension, which includes dialysis. I'm also a subspecialist in solid organ transplantation medicine, particularly kidney and pancreas transplant. This is a community service um, in response to a request from my friend, Dr. Buchi Samson, who asked me to make this video for the benefit of dialysis patients in Nigeria, as well as a center they had recently developed in Amich, which is in Anambra State. In summary, the kidneys are two organs, each located at the flanks of the trunk. Each one of them has about 1.2 million nephrons. The average is 1 million per kidney. The nephrons are the basic building block of the kidney, just like the wall of a house. The basic building unit of the wall is the brick or the blocks that make up the wall. So these nephrons, they act like coffee filters and filter excess water that you have, excess electrolytes, and they also help you in performing all the necessary kidney functions, some of which I'm going to enumerate here. When the kidneys are working very well, they perform these basic functions. One is to control the amount of volume, amount of liquid, or amount of water, in a nutshell, that your body has. If you have excess water, the kidney will remove the water. If you don't have enough, the kidney is going to almost shut down to prevent you from losing the water that you have, so you do not die of dehydration. So if you're walking through a desert, the kidney has a means of sensing that you don't have enough water in your body, and it's going to prevent you from making urine so that you don't dehydrate and die. Another function that it performs is controlling your electrolytes. Electrolytes are salts or components of salts. I'm going to mention a few. One is sodium, which is the one you have in your table salt called sodium chloride. You have potassium, which is another source of, it's a kind of salt also, or an element also, we get from food, such as banana, orange juice, as well as potatoes. Then we have another one called magnesium. Then we have phosphorus, and we have calcium, and others, but these are the most important ones. Your body cannot function without them. You need magnesium, you need calcium, you need phosphorus for you to maintain adequate bone structure. If you don't have enough, you're not going to be able to grow. And if you're already grown and you start losing them without replenishing them, you're going to start having fractures. If you move around, your bones will break. Your muscles cannot contract without calcium or phosphorus, including magnesium. Therefore, you need these elements in form of ions in your body to help your body function. Parts of your body are made up of muscles, none of which can contract without these elements. So if you don't have them, you're going to die. So kidney performs a life-saving function. The other is your red blood cells, which we call blood. If you don't have enough red blood cells, you're going to die. If you start depleting them in number below normal values, we'll say you have anemia. If anemia is not treated, you're going to end up having the consequences of anemia, one of which is heart failure and fatigue and others. So the kidney has the job of providing one of the chemicals that your body needs to make the red cells. The red cells are made in your bone marrow, and they are usually made of iron and some proteins. So the main component of the red cell sitting inside that makes the color red is called hemoglobin. And hemoglobin is nothing but iron and some proteins called globulin. And when they are combined, they form hemoglobin. And that is the oxygen binding part of the red cell. Without your red cells, you cannot use oxygen. If you don't use oxygen, then you die. And so you can't make red cells unless you have normal kidneys. And if you don't have normal kidneys, you have to get this chemical that the kidney supplies the bone marrow to make red cells. You have to get it from the outside. This chemical is called erythropoietin. The other is your bone structure and architecture. Your bone structure is heavily dependent on the kidneys because the bones are made of primarily of calcium, phosphorus, and magnesium to some extent, but primarily calcium. So when you eat food that contain or are rich in calcium, you digest the food in your intestinal tract, and then it's absorbed into your bloodstream. So when you are lacking in calcium, the kidney knows. So it's going to make a certain chemical from vitamin D called active vitamin D, which will travel through the blood to go to the gut, which is intestine, and then encourage or order or instruct the body to absorb more calcium from the digested food. So when you eat vitamin D, whether you take it as tablet or get it from your food, the vitamin is not useful until the kidney converts it to an active form that is useful. First, the sunlight will convert it under your skin to a certain chemical. That certain chemical is going to go through other processes and get to the kidney to form the active vitamin D called 1,25-hydroxycalciferol. You don't need to remember this long name. Just need to remember very active vitamin D. So you don't have vitamin D functioning unless the kidney makes it active. So you see that the kidney performs a lot of life-saving functions. So when the kidneys stop working, we call it a kidney failure. When the kidney is damaged but it has not stopped working completely, so we call it acute kidney injury if it is new. But if it continues to go on regardless of treatment for months, then we designate that to be chronic kidney disease. And then eventually, if it does not respond to treatment, you will continue to progress until you develop what is called end-stage renal disease, meaning the kidneys are dead. The kidneys, when they are dying, the nephrons are what are dying little by little. And as you get older, you begin to lose some nephrons. Therefore, the kidneys of an 80-year-old man and the kidneys of a 5-year-old are not the same. The 5-year-old will have more nephrons than the 80-year-old because you keep losing the nephrons as you get older. However, if you have kidney failure, as I just described, whether it's acute kidney injury or chronic kidney disease, or whether it is end-stage renal disease, which is complete death of kidneys, you need something to help you. So you need the machine called dialysis machine to be used by the experts to clean your blood and perform the same function your kidneys perform. And the component of this is called a dialyzer. It's an artificial kidney that is manufactured and then placed in that machine, and the computer is going to direct the dialyzer and the machine to do exactly what the kidney does in order for you to be alive. when somebody is delivering a baby and has a lot of blood loss, the person can develop acute kidney injury in which the nephrons are damaged, usually the tubes in the nephron. The nephron is made up of many components, one of which is like a filter paper like you have in your coffee pot. So when you make coffee, you pour the coffee into the coffee filter, then the filter is going to drain the coffee into your cup while it prevents the solute part, which is the solid part, to remain on the filter. And so what you have just done with this coffee is what the kidney does. When things or everything will come with the blood and get to the kidney is going to remove urine through the filters of the nephrons, as well as excess salt and excess water, and then let the rest return back to the blood to do their job. And it does this round the clock, 24 hours, all of your life. So when it stops doing that, then the machine has to do it for you. So when the machines are going to do it for you, we call it dialysis. We have two major different types of dialysis. Hemodialysis, meaning the blood dialysis, the one you use your blood to do. And then there's one called peritoneal dialysis, which you don't need the blood. We just put a catheter underneath your peritoneum, or in the peritoneum, which is underneath your skin and underneath the muscle. It's a layer that covers all the intra-abdominal organs and separate them from the muscle and the skin. That layer is called peritoneum. So we can use that peritoneum to serve like a filter paper for somebody whose kidneys have died. And then we can put some chemicals and water, particularly a very high concentration of glucose, which is sugar, into that peritoneum, and it's going to use osmosis to draw water and urea and other particles from your blood into the peritoneum, and then it's going to be removed using gravity by what you call a CAPD, or you can use machine to do that while you're sleeping, and it's called CCPD, which is the machine does all the work for you. You don't need to participate except to hook yourself up to the machine before you go to sleep. But today we are going to concentrate on hemodialysis. We can deal with peritoneal dialysis on another video. Hemodialysis, to summarize it, is, as I described, is the machine being equipped with computers and the dialyzer, that's artificial kidney, to serve you when your kidneys are no longer functioning. And so how do we accomplish this? First, if it's acute kidney injury in which like somebody has acute illness, it can be pneumonia, it can be heart attack, it can be stroke, anything that affects your kidney. And like I mentioned before, everything you eat and everything you drink go through the kidney. The liver is going to help do detoxification, make it less poisonous, and the kidney will have to remove them. The gallbladder can do a little portion of it through the stool, but majority will go through the kidney. Therefore, if you're taking any medicine that you don't know anything about, you can be killing your kidney every day without knowing it until the kidneys will quit working. So this is a good information for you. Don't take any medicine unless you are advised by an expert who is going to tell you the side effects, the dose, and how it's going to affect your kidney or not. So if your kidney is damaged, but it's not damaged completely, through these other means I've just described, from illnesses or from blood loss, like somebody has an accident, you lose a lot of blood, your kidneys will fail. This sudden kidney failure is usually called acute kidney injury. We used to call it acute renal failure. So what we do then is we put a catheter. This catheter is going to have the shape of a Y loop, like in a sense, like a catapult. So the end of the catapult, you put it underneath your collarbone, usually on your non-dominant side. So if you are right-handed, we put it on the left side. There are major blood vessels running below the collarbone one of which is called subclavian vein. It's a big blood vessel. So when we put a catheter, we cannulate, we put a needle underneath your skin and get to the vein, and then we're going to advance this catheter into that subclavian vein, and then hook up the entire catheter. They have names. What general name is hemodialysis catheter. There are different kinds: Tessio catheter, and tunneled or non-tunneled catheter. But the summary is that you get a catheter, a very big catheter underneath your collarbone. The idea is for a lot of blood to be coming out of you through this catheter. When it comes out, you have two sides of the catheter. One we call the venous side, and then the other one is the arterial side. So the blood is going to come and go to the kidney machine, and then the kidney machine will clean the blood and remove all the wastes, remove excess water, remove excess salts, and then return the blood back through this other side of the catheter back into your body, which is your blood circulation. And that continues, and you keep doing it for hours, most likely 3 to 4 hours. Sometimes every day, sometimes every other day, depending on the patient's needs. When this is done, you have to make sure that you do not replace the same thing you are removing. So if you are removing 2 liters or 3 liters of water in a day, you don't want to drink 3 liters of water because you just put back what we have just removed. So in such a circumstance, we have to regulate the amount of water that you drink and total amount of fluid that go into your body and total amount that we have to remove. Because if you maintain too much volume in your blood vessels, eventually it's going to back up into your lungs. And when the air will come into your lungs for you to breathe, there won't be enough space in the airbags for the air to go in. And then you're going to smother to death as a result of too much water in your lungs. This water is not supposed to be there. And of course, you know that when the air will come into your lungs, it is that hemoglobin in the red cell that the kidney helps you to synthesize or to build is what is going to capture the oxygen that comes into your lungs and then transport it to the rest of your body to produce energy. So you don't have kidneys, you're not going to be alive. So this is how dialysis is done for somebody with acute kidney failure. Acute kidney failure, most often than not, affects the tubules in the kidney, like small pipes that deliver water from the city water to the gardens. The same way the kidney has big pipes and they have smaller branches where by the time they end up to form the filter, they are too small in size. So the big tubule, when it's damaged, 99% of the time, if it's the only damage, it will recover. So if you dialyze this person or treat this person very well, the person is going to recover the function anywhere from 8 to 16 weeks. On the other hand, if you don't do the dialysis well, you're going to dry the person up and you damage the tubes more, and then from damaging the tubes, you damage the other parts of the kidney, which we call the cortex. And then you go from having acute tubular necrosis, which is death of the layers of the tube, to the death of the actual components, other components of the kidney, we call it cortex. We call it a cortical necrosis. Once cortical necrosis is involved, it's a permanent damage. There's nothing you can do to reverse it. Therefore, it is prudent that somebody who is going to put you on dialysis when you have acute kidney injury knows exactly what he's doing. Because if he does what he's not supposed to do, it will shut your kidney down forever. The other type of kidney failure, as I said, is the chronic type, which may end up to complete death of the kidney, called end-stage renal disease. It's of note to know that the common causes of kidney failure in Nigeria, in America, and most parts of the world, number 1 is diabetes, number 2 is hypertension, number 3, if grouped together, you have glomerulonephritis, which is many diseases causing inflammation of the kidney. And then there's something we call polycystic kidney disease that is genetic or can be sporadic, meaning your kidneys have a lot of cysts taking over the nephrons. So where there are no nephrons, then the kidneys are not adequate enough to serve you because they are replaced by cysts. and some of them run in families. One person has it, the other person has it. It's likely you can have 8 children in one family, and 5 of them may have polycystic kidney disease and end up in dialysis. They don't know what dialysis is. Their kidneys fail. They don't know the kidneys fail. They die. So I remember that if you have too much potassium in your blood, if it's not removed by the kidney through the urine, you die. So in dialysis, we use the machine to remove excess salt, one of which is potassium. And if you don't have enough, we use the same machine to put some in your body so that you can have adequate amount. We just have to find a balance. So when we want to dialyze somebody whose kidney has failed completely, we start preparing the person for dialysis permanently until he gets a kidney transplant. In order to dialyze that individual, we have to put a fistula, which is a circuit at the elbow area, what do you call that, the brachial area. We use your vein by a surgeon and attach your vein to your artery side by side and create a circuit. Or they can do end to end to create a circuit. That circuit will make blood to coming out of your body, going to the arm. It's going to be circulating around that circuit. So we put needle, one on each side of the circuit, and connect it to the machine. The blood will come out and go through the arterial side and go into the kidney, which is artificial kidney on the dialysis machine. The machine and the artificial kidney will do their job and remove the waste and excess water, excess salt, and then the blood will return through the venous port back to that same circle. And it continues to do that because it goes into the body, comes out, and goes through the circuit, and then continues until you do it for 3 to 4 hours. That's what is done in America 3 times a week. In Japan, they do it 5 times a week because it's expensive. Not every country can. The kidney works 24 hours every day. So if you're doing artificial treatment, it should be 24 hours every day. But because nobody has enough money to do that, and it's cumbersome, not compatible with quality of life, so they do it intermittently, 3 times a week. Japan would do maybe less hours or do the same number of hours, but 5 times a week, depending on if the patient is willing to do so. It's of note also that you can actually dialyze yourself at home. When you buy this machine, they come in and train your wife or your children on how this machine can be used. You get the supplies and you do your own dialysis when you want to, whether you want to do it in the morning, afternoon, or night. Otherwise, you have to go to dialysis center where it's done during the day and get it done there for 3 or 4 hours, 3 times a week, and be discharged home. During this process, they're going to give you these chemicals that the body will need that the kidney can no longer make. One is erythropoietin, the one that assists you in making red cells. You have to inject it into the patient, either into the machine or into the patient yourself directly. When he's not on dialysis, you put it in the circuit, and the patient gets it through that way 3 times a week. Where you're giving the erythropoietin, you also need to make sure the patient has adequate amount of iron to build the red cells by the bone marrow. If you're not eating enough iron or you're using too much iron to produce your red cells and you are low in iron, the dialysis doctor needs to know when your iron is low and he needs to give you more iron. The iron can be given by mouth or can be given intravenously depending on how low it is. Calcium, because the kidney is no longer there to give you the active vitamin D that helps you to withdraw calcium from the bone and dump it into the blood when you're low in calcium, or help you absorb calcium from the gut. When it's no longer there, you have to give that same chemical to the patient either by mouth or through the machine. When it's given by injection, it's called Calcijex. You inject it into the machine 3 times a week according to the need of the patient. Remember that the architecture of your bone is dependent on calcium, phosphorus, and magnesium. So there is an organ, or there are glands, not organ, in your neck. They're called parathyroid glands. They help to send signal to withdraw calcium from the bone, and then when you have too much calcium, it's going to suppress that stimulus, and then you're going to begin to deposit calcium back into the bone. So the kidney plays a vital role in this parathyroid, calcium, and bone axis. That's a different topic for another day. And then um, once this person is on dialysis, it's going to be permanent unless you have kidney transplant. And to make sure that a patient is getting adequate dialysis, not just bringing blood from the body into the machine and back, and the patient sits there for 3 to 4 hours and he said dialysis has been done. No, there is a way it's done to be efficient and adequate for the patient. And we have to measure the amount of urea that we remove from your body each time we dialyze you. We can do that. Machine can help calculate that, and we can do that every week. I can do that every month to see whether you're getting adequate dialysis or not. If you're not getting adequate dialysis, we're going to find out why. Is it because the circuit is not working well? Or is it because the machine is not working well? Or is it because the tech who is doing dialysis or the nurse doesn't know what he's doing? Because if you don't know what you're doing, you're going to under-dialyze the patient. And the catheter, the size of the catheter you use also will determine how well the patient is dialyzed. The speed at which the blood will leave the body and come to the tubes and return back to the body matters a lot. Because if you don't have tube with adequate diameter, then only a small amount of blood is going to be coming out, and therefore you're going to have just little dialysis, because the amount of blood that comes to the machine is what the machine is going to clean. If you have a lot of blood coming, it's going to clean a lot of blood. If you have a little amount of blood coming, it's going to clean a little. Therefore, the catheter size and the needle size matters. What I saw in Nigeria is people using very tiny catheters. They put one in the groin and put one in the arm. I think they're just improvising. Nobody else does anything like that in this world. Therefore, the patients are not getting adequate dialysis unless they do what I just described here. The other is that diet plays a lot of role in dialysis. You don't want to be drinking exactly the same amount of water we're removing. You need to drink less. So we encourage patients to drink only 15 cc of fluid in 24 hours if you're doing dialysis 3 times a week. Because if you accumulate too much fluid, we have to remove too much when it comes to dialysis. And when we're removing it at the very fast rate, so we can get it done within 3 to 4 hours, you are bound to cramp. You're going to have a lot of muscle spasms and cramp, and it's painful. And sometimes your blood pressure will drop suddenly because they're pulling the fluid rapidly. And when it drops suddenly, you need blood to go to other vital organs. It doesn't go to your brain, you're going to pass out, or you can have a heart attack. So it's important that a dietitian manages the patient to, with the nephrologist, to make sure the patient is drinking what is prescribed for the patient, and then the food the person is eating doesn't have too much phosphorus, doesn't have too much potassium, and then we also want the patient to have adequate protein intake, because kidney failure, when it's at the early phase, is a high catabolic state. It makes you break down your muscles as you're trying to increase your metabolic activity to replace those things that you're losing. And so you have to have enough protein to replace what you're breaking down. And then finally, the complications of dialysis. The number one complication we see is infection. If you have infection, it's not adequately treated, the person dies. Sometimes the bacterium will travel to the heart valves and cause infection of the heart valve called endocarditis. And so whenever you're dialyzing someone and the person has fever or chills, you should worry about infection. You need to get blood to the center for culture and then give the person antibiotics empirically. Give antibiotics as though he has infection, because most often than not, the patient has fever in dialysis or after dialysis. Most often than not, it is infection. At the early part of the process, the patient is just beginning dialysis. The dialyzer, which is the artificial kidney, if it's not biocompatible, because it's made up of certain chemicals to create the tubules, the fibers, they are not compatible with the body. It can create immunologic response in which your body is going to generate fever or chills. That may seem like the person has infection, and sometimes hypotension, wheezing, shortness of breath. So if you see that, you need to recognize that as an allergic reaction coming from the dialyzer. But if you have a biocompatible dialyzer, this doesn't happen. If it does, it's very minimal. So one should be able to know that if you don't have this dialyzer reaction, particularly after the first 2-3 dialysis, and you start having fever or chills, that most often than not, that's infection. If it's not treated, the patient may die. And so when you sense there is infection and you're using a catheter, when you send the culture is positive, you need to remove that catheter and then put another one, preferably put another one temporarily in the groin to dialyze every day and remove it, dialyze again, remove it, to give the body enough time to clear the infection that is in the blood. So after 1 week, you can put the new catheter in, hoping that you have treated the bacteremia or the infection in the blood. Other complications is that if you have too much calcium in your body and you have too much phosphorus in your body, they can bind and form stones. Wherever you deposit this complex, if you deposit in the brain, you're going to have seizures. Deposit in the heart, you have heart attack. Deposit in the tiny blood vessels of the hands and the feet, you're going to start having necrosis and the gangrene of your toes, and you can lose your toes and your legs. And then others, if you have a situation where you have dysfunctional graft or fistula, the patient's arm can swell as long as, because of inadequate circulation. The arm can get as big as somebody's leg. So when you see somebody's arm getting that big, suspect that. When we put the catheters to dialyze, we try to do our best not to put it in the subclavian vein, which is one in the collar. We use the internal jugular vein, which is in the neck, because it prevents this subclavian stenosis, which creates this poor circulation in which your arm begins to get big. So it is not ideal to use the subclavian veins. That's what most people like to use, particularly in Nigeria. No, use internal jugular vein and save the patient's subclavian veins, because those are going to be his lifeline when you put the fistula or the Gottes graft that you're going to use for long-term dialysis. And then other things, as if you have a fistula or graft, you can develop aneurysm, and you have to watch it, because if you bust open, the person is going to bleed out. And of course, we use heparin during dialysis to prevent the blood from clotting in most patients, unless it's contraindicated. This is the summary of the basic dialysis. One must remember that dialysis is not a treatment for kidney failure. Rather, it's not a cure for kidney failure. It's a temporary treatment that serves as a bridge between kidney failure and kidney transplant. So every astute nephrologist anywhere in the world is driving for his patients never to be on dialysis. So if you see that somebody has diabetes or hypertension or any other chronic kidney disease, you keep watching it. By the time the patient gets to stage 4 kidney disease, you would have started the patient on transplant evaluation if the patient agrees with transplant. You don't have to get on dialysis for the transplant. You can do what is called preemptive kidney transplant, in which if somebody is going to donate the kidney to the patient, you evaluate both of them if they match and qualify to donate the kidney. Then you want to transplant that kidney before the person gets to end-stage renal disease, where the kidney doesn't function anymore and needs dialysis. But of course, if that's not possible, the person remains on dialysis until such a time that he has a kidney transplant. I had already done a video on kidney transplant, and if you want to know more information on that, please access that video. You can go to my website, my video site, and then access the one on kidney transplant. It's very informative, and it's going to help you make the right decisions. I'm sorry this video is long, it's about 35 minutes, but I couldn't shrink it anymore, and at the same time give you adequate information that you need to have both the patient and the technician when they are giving you dialysis. We must remember that when you're on dialysis, if you're not getting erythropoietin, you're not getting calcigex, which means you're not replacing these chemicals that the kidneys make it means you are doing half of the work and you are going to die. I've seen it in Nigeria time and time again. And some people say it's cost, and I understand that, but at least you want to know what you need. If you don't have the money to do that, then you have no control over that. But if you have the money to pay for those things and they're not giving it to you, you need to demand them. And then if you're doing dialysis and you never see your nephrologist, that's a crime. It's not just a more practice. That's a crime. And that's what happens in some parts of our country where nephrologists play God and you're trying to reach them, they will refuse to answer. In fact, I witnessed a case, sadly enough, in which a patient was spiking fever, and I advised them to draw the blood culture and set the patient on antibiotics empirically. They called the nephrologist. I don't want to say his name here. I hope to meet him in Nigeria when I get home. They called him, he will not answer. They sent an intern at the hospital to go and draw the blood. She's never ever been trained to know how to draw the blood from the dialysis catheter. The nursing staff said they didn't know how to draw it. The nephrologist told them, okay, you go to your, when they called the nephrologist again, he says, oh, you go to your doctor. Let your doctor draw it. And then the patient got frustrated and left. And I told the sister when the patient was leaving that this is predictable. He would die. And less than 10 days later, he died. And he was under 60 years old. So going to dialysis is not just going there, sitting there and getting somebody pull blood out of your body, pass it through the machine and put it back, and then you pay money and go. You need to know what you need, and those who are doing the dialysis for you, if they're compassionate enough, if they are healthcare workers that are there for what they're supposed to do, they need to have this information, and they need to ensure that their patients get these things. If their nephrologist is not doing what they're supposed to do, you confront the nephrologist. If not, you change doctors. You don't have to go to any particular center. I know it's cumbersome, I know it's challenging, but this is one of the reasons why it is prudent to make sure you prevent kidney failure before you get there. But if you can't prevent it, be armed with what you need to have adequate treatment and preserve your life. If indeed you need transplant, which most people would need if you have chronic kidney disease, you need to start early, to start talking to family members and friends. Don't participate in stealing people's children, harvesting their organ, or selling their organ, or getting somebody, convincing him to sell a kidney to you without the person's, what I call intelligent consent. Because if you lie to someone and say, oh, just give me one kidney, the other one, there's no problem. Yes, there may not be a problem if it's managed well. But some people who donate kidneys still end up having kidney failure. It's rare, but it happens. And if that happens in America, we'll put them number one on top and transplant them immediately, because they gave service to the country by giving somebody his kidney or her kidney. I hope this helps, and I pray that the hospital we are trying to put up in Ojoto, that is going to embark on kidney transplant in the next 24 months or less than that, will help us solve some of these problems.